Today let's talk about shock. So shock is by definition inadequate tissue perfusion. When we say tissues, it is ultimately the individual cell which is compromised of nutrients and oxygen. So there are different types of shock, including hemorrhagic shock, cardiogenic shock, septic shock, neurogenic shock. But in trauma, we are mainly talking about hemorrhagic shock, which is called hypovolemic shock as well. Hemorrhagic shock we can classify into 4 classes: class 1, class 2, class 3 and class 4. And in fact, it is easy to remember the blood loss. The percentage is quite similar to the tennis scoring system. Class 1 is less than 15%, class 2 is 15 to 30%, class 3 is 30 to 40%, and class 4 is more than 40%. So in this equation, actually our main important parameter is blood pressure in the body. The body is trying with all physiological parameters, mechanisms to maintain the blood pressure. So in class 1 and class 2, somehow with physiological mechanisms, the blood pressure will be maintained. The blood pressure starts to drop only with class 3 and class 4 shock in hemorrhagic shock. And there are 2 equations we should remember with regards to the hemorrhagic shock. Number 1 is the blood pressure equals cardiac output into the peripheral resistance. Number 2 is cardiac output equals the stroke volume into heart rate. So in class 1 shock, what happens is less than 15%, that is less than about 750 ml in a 70 kilogram adult, blood loss. At that particular time, due to the blood loss, stroke volume drops. In fact, we know in a normal adult, the cardiac output is about 5 liters, stroke volume is about 70, and heart rate is about 72. So class 1 shock, when the stroke volume drops, the body mechanism, physiological mechanism somehow increase the heart rate and maintain the cardiac output. By that, the cardiac output is maintained, the blood pressure is maintained. So when it comes to class 2 shock, further blood loss, stroke volume further drops, heart rate is maximum increased, cardiac output tends to decrease. When the cardiac output decreases somewhat, what the body does is increase in the peripheral resistance. Ultimately, somehow the blood pressure is maintained. And when it comes to class 3 and 4 shocks, lot of bleeding, stroke volume further drops, heart rate is maximum, cardiac output has dropped, peripheral resistance is maximum, the blood pressure starts to drop. That is how in class 3 and class 4 shocks, the blood pressure drops, whatever the physiological mechanisms acting in the body. So as you know, depending on the class of shock, in hemorrhagic shock, we should identify at the beginning without waiting until the patient comes to the class 4 shock, which is irreversible. Therefore, the management of hemorrhagic shock starts at the beginning. So early detection is very important. And how do you manage? Of course, when the patient is losing blood, we have to replace the body fluids. So ideal fluid in hemorrhagic shock is the blood. When the patient is losing blood, it should be replaced with blood. But the problem is the blood will take time. So to get cross-matched, group-specific cross-matched blood, it will take at least about 40 minutes. So till then, we have to manage the patient at the beginning to resuscitate the patient. So till we get the blood, the fluid of choice is crystalloids. As you know, there are colloids, crystalloids. But colloids expands the intravascular component more, which is good, but it has a lot of disadvantages, like anaphylactic reactions, and some renal impairment, and it is not freely available and expensive as well. So due to all these problems, we prefer crystalloids. So as you know, the crystalloids routinely we come across the normal saline, which contains sodium chloride, and Hartmann's. So those are the two widely used crystalloids. So how do we infuse these fluids into the body in a shock patient? What do you think? Central line, peripheral line? What do you think? So in case of an emergency shock, the central lines takes time and needs expertise. So that is not the best technique in an emergency. So we prefer some peripheral lines. So peripherally placed cannula is the best. So we recommend 2 large bore cannulas to the 2 large veins on both hands, both upper limbs. So when you say large bore, as you know, the largest bore cannula we get is 14 gauge, which is orange color. So we need at least 2 large bore cannulas to resuscitate a patient in hemorrhagic shock. Then only we can infuse the fluid in a good flow rate to the body to save the life of the patient. See some cannulas we use in resuscitation of patients with hemorrhagic shock. So if you can see here, there are different sizes of cannula. The largest bore cannula is the 14 French gauge. The color is orange, and from that there is a different color range going to 17, 18, 20, 22, 24, 26. So ideally speaking, in managing class 3 and class 4 hemorrhagic shock patients, we should use at least 2 wide bore cannulas. That means 2 14 gauge cannulas. And in the meantime, the type of fluid, as I told you before, the crystalloids is the fluid of choice until we get blood. The widely available normal saline or Hartmann solution, which has potassium in addition to the sodium chloride. Those are the 2 crystalloids we widely use in managing for the initial resuscitation of hemorrhagic shock patients. So at the same time, once we have put the peripheral lines, if you get the expertise, later on you can go for a central line. And at the same time, in case of a child, you have a difficulty in putting peripheral placed cannulas. Another technique is intraosseous, using the bone in the leg, which is the tibial bone. The bone marrow is quite vascular in children, so we can use the intraosseous method to infuse at the time of shock. So at the same time, this is about replacing the fluid, but remember, very important, to close the tap. At your home, when there's a water leak, tap is broken, water is leaking, no point pumping water into the tank. We have to close the tap. So it's very important that if there's a obvious bleeding, maybe external bleeding or internal bleeding. In fact, in trauma we call 1 on the floor and 4 more. 1 on the floor is external bleeding, 4 more is chest, abdomen, pelvis and the long bones. So somehow we have to stop the bleeding while we are replacing. Thank you.